and my name is Preston. I'm a fourth year student at University of Colorado, and I'm one of the leaders of the mentorship program for Pathways, as well as a member of the social media team here. Super excited to announce that we're starting a mentorship program between residents and medical students, and between medical students, specifically fourth years and third years, with the first and second years interested in getting more involved in PM&R, as well as applying to PM&R. And so we're hoping to get this program rolling out by October 1st. We're currently in the process of recruiting residents, and recently established a relationship with PM&R scholars as well, which is plugged in with a large number of residents. And so we will get that all ready for you. The curriculum will basically just entail a quarterly meetings with the mentor, which is flexible depending on the timing and the schedule that'll work for either the mentor or the mentee. But I'll go ahead and drop a Google form sign up, just to field some interest. You're not obligated to this relationship if you sign up on this interest form. It's just showing interest while we get all the details ironed out. And so if you have any questions, I'll post my email in the chat as well. Thanks, Hunter.
Awesome. All right, next I'll pass it over to Kate.
Hey everyone, my name's Kate. I'm a fourth year student at the University of Kentucky College of Medicine. Tonight I'm going to introduce our first speaker, one of the people who really got me interested in PM&R to begin with. It is Dr. Nick Elwert. He is an assistant professor in the Department of Physical Medicine and Rehabilitation at the University of Kentucky. He graduated from Lincoln Memorial University DeBusk College of Osteopathic Medicine and completed his residency training in PM&R at the University of Kentucky. He currently serves as the program director of stroke rehabilitation at Cardinal Hill Rehabilitation Hospital in Lexington, Kentucky, and serves as the resident research advisor and associate residency program director for the UK PM&R residency program. His passions in PM&R include neurorehabilitation, specifically stroke rehabilitation and spasticity management. He is equally passionate about resident education, diversity, and inclusivity, as well as networking with the use of social media. While not working, he enjoys rooting for the Cincinnati Reds, Kentucky Wildcats, and Cincinnati Bengals, and spending time with his family. I'm happy to pass it over to Dr. Elwert tonight.
Well, hey everyone, Hunter, Kate, Preston, all of Pathways, thank you guys so much for letting me kind of kick off our PM&R bash. I truly am honored, and I'm excited, and it's a great turnout to have 48 people come out on a Monday night at 8 o'clock Eastern. I mean, you guys could be doing a lot different stuff, so we're really happy that you're here. So, I see kind of a mix of student designations. And so what my lecture is going to be is really an intro to PM&R. So I'll be very upfront with you. Some of the fourth years that are sold on PM&R, kind of in the thick of audition rotations and going through asking for letters and everything. Some of this stuff you might find a little boring, and for that I apologize. But for those that are brand new and have never heard of what PM&R is and may think that PM&R is pain medicine, well, let me tell you, it is so much more. So I'm stoked. Towards the end of the lecture, we'll kind of talk about like what my day looks like, and kind of some different career opportunities that you can take in PM&R, because it is quite extensive. And then I have until about 8:30. I would like to end a couple minutes early just to make sure that I can answer any questions you guys have about PM&R in general, about life as a resident, or life in residency. So let me go ahead and share my screen and we'll get started, guys. All right. Kate or Hunter, can I get a thumbs up? Can you guys see me? Perfect. All right, guys. So you gotta kind of when I'm starting off a lecture about PM&R, you gotta know kind of a little bit of who I am besides the intro that Kate said. So I'm a graduate of Wilmington College in Wilmington, Ohio. I got my BS in biology and a minor in chemistry, and I went to the Lincoln Memorial University DeBuss College of Osteopathic Medicine in Harrogate. I'm now starting to date myself and say that there was only a Harrogate campus and not also a Knoxville, Tennessee campus. During my time there, I did what's called a pre-doctoral fellowship. So I knew very early on that I wanted to do PM&R. Actually, as a first-year medical student, I was very interested in PM&R. I knew that's what I wanted to do. And so as I finished my second year of medical school, the opportunity came up to apply to be an anatomy and OMM fellow. For those that may not know what OMM is, it's called osteopathic manual medicine. And it's essentially for the DO and OMS students, please don't be mad at me. It's kind of like chiropractics, but kind of not. I think that's a way to describe it. It's essentially using your hands for manual manipulation. And so because I knew that I wanted to utilize that in my practice and I wanted an advanced anatomy education, I applied for and was accepted to be a fellow and got my master's in anatomy during that time. As I mentioned, I knew I was wanting to go into PM&R. And I'm kind of a planner, I'm very much of a planner. And so I had my life planned out to where I was going to do sports and spine medicine. I really wanted to go to UK for a myriad of reasons, and then wanted to go do fellowship. I was going to be that person that ran onto the field, saved the day for the star football player. Everyone's rooting in the crowd. That's what I thought I was going to do. And then I checked off one box, matched into UK, went into residency. And then as a second year resident, I fell in love with neuro rehab and particularly stroke rehab. And so one thing that we'll talk about is a PM&R as a whole gives you exposure to so many different aspects of rehabilitation and rehabilitative medicine. And for me, I love musculoskeletal medicine and I still practice it and it's still part of my practice, but I am passionate about neuro rehab. And, you know, to this day, I'm grateful for not only the program I went to, but for the field that I pursued, because I got to do what I'm passionate about. And I love waking up every morning to figure out, you know, how can I help my patients? As you know, I mentioned, I matched at UK and I'm a graduate of our program and I loved it so much. I wanted to stay and continue to help grow. And so now I'm an assistant professor of PM&R. I am our stroke rehab director. And then I love academic medicine. I love education. And so I'm currently our assistant program director. So that's a little bit about me and how I came into PM&R and how I'm doing what I'm doing today. So now for the fourth years, this may be the boring stuff. I apologize, but we got to go back to our roots. PM&R, or you'll also hear physiatry or physiatrist. It actually has Greek etiology from physiakos and iatria, which means physical and art of healing, and it's known as physical medicine and rehab. So you'll hear people use those terms interchangeably. I'm a PM&R doc. I'm a physiatrist. You'll hear some people say physiatrist. That just doesn't roll off the tongue as well, in my opinion, as physiatrist, but it's kind of tomatoes, I guess. To give you a little bit of a historical perspective. So we actually got a lot of our beginnings and a lot of our history through World War I and World War II. So really the modern medical specialty began to develop during World War I and World War II with our injured veterans and the polio epidemic. There was such a need for rehab of those individuals that's really where we started to make a name for ourselves. And in 1947, we officially became recognized as a medical specialty. And today there's over 11,000 board certified physiatrists nationwide. And I guarantee you that number is higher. So there was a need, we filled it. And that's kind of how we came to be. So for a PM&R approach or a physiatric approach, we really look at two main things. We look at function and we look at quality of life. So what kind of function does someone have and how can we improve that patient's quality of life? And it's really an integrated care with pharmacologic and non-pharmacologic modalities. So whether that is from a pharmacologic perspective, if you talk about stroke rehab, how am I treating someone's tightness or their spasticity? How am I helping them, as I kind of say, get a pep in their step? So utilize neurostimulants. And then non-pharmacologic measures. How are we utilizing our therapy modalities? And then, we also need to be healed, not only from a physical perspective, but from an emotional and spiritual perspective, if someone is spiritual. And so our counselors play a vital role. So it's really a combination of the pharmacologic and non-pharmacologic modalities, and really an interdisciplinary team. I always tell the therapists, the nurses, I can't do my job without them, and vice versa. And all of us play a very vital role into improving someone's function in their quality of life, whether that is in the outpatient setting or in the inpatient setting. Now, not only in the inpatient setting are we working with our therapists, our nurses, our counselors, but also in the outpatient setting, you also have an interdisciplinary team. It just looks a little bit different, and there's a little bit more distance between you. And that's where you're working with the patient's primary care provider, different specialists, and then physical and occupational therapist, speech therapist. It looks a little different, but no matter how you practice, you are utilizing an interdisciplinary treatment team. So I've mentioned now a couple of times that our goal is to improve function and maximize quality of life. We, use what you would call a holistic approach. So, we're not just looking at, hey, here's some elbow pain. How can I treat your elbow pain? It's, hey, you've got some elbow pain that is preventing you from being able to hold your cup of coffee in the morning. How can we help that elbow pain and improve your function? But then also, where's the elbow pain coming from? Is it causing some compensatory shoulder pain? Is it causing compensatory wrist pain? Looking at the patient as a whole and really centered care and approach. And not only do we want to assess our patients and provide that holistic care, but we also want to work on the prevention of potential impairments that may arise from someone's injury. So I've mentioned and kind of alluded to is we have really an inpatient and outpatient setting if you really want to look at it that kind of cut and dry. So to get a little bit more into the inpatient aspect, so as the physician, you are leading the interdisciplinary team. And that interdisciplinary team includes physical and occupational therapist, speech therapist, a social worker or a case manager, a psychologist or a neuropsychologist or a rehab counselor, and a chaplain, dietitians, nutritionists. We're all working together to figure out, okay, again, let's use a stroke patient, for example. Someone has had a stroke. How can we improve their function so that they have the highest quality of life possible? And as the doc, as you are leading the team, you're overseeing the medical component, as well as, working with the therapist to say, hey, how can we maximize someone's activity, with them? So for example, I'll have therapists that come up to me on the unit and they say, hey, Dr. Nick, do you think we could get a AFO for this patient? And so we'll watch the patient walk and say, you know what? Yeah. I think by able to provide them with an AFO, or for those that may not know what an AFO is, it's an ankle foot orthosis. And so that's going to help someone walk, help them clear their foot. So they're going to be able to participate in therapy more. So that's just kind of the ways that not only are we seeing the medical component, but also helping prescribe therapies and, again, working as a team. From an inpatient perspective, you're seeing all different types of diagnoses: spinal cord injury, brain injury, stroke, multiple sclerosis, polio, burn care. You see musculoskeletal issues, general rehab, peds rehab. You see a little bit of everything and anything and guiding those patients to their functional recovery. Here on the right is a picture of where I work. So I work at Cardinal Hill Rehab Hospital. So it is here in Lexington, Kentucky. It is a 232-bed freestanding rehab hospital. We have a full outpatient clinic, some therapy pools, and then we have 7 different units to provide care for our patients in need. So that's inpatient. What does outpatient look like? I said it kind of looks the same, but also different at the same time. Now, this has a lot of text. I normally hate a lot of text on a slide. But to kind of sum it up is where you're looked at as the experts for non-surgical management. And this is non-surgical management of musculoskeletal issues, orthopedic injuries, occupational injuries, or sequelae of different diagnoses. So after a stroke, someone's going to have spasticity or tight muscles. How am I going to address those? Neurogenic bowel and bladder. Skin issues. If someone is unable to move an arm and a leg, or if someone has a spinal cord injury and can't move their pressure injuries, we're looked at as the experts in utilizing our colleagues in wound care as to, okay, how can we make sure that we maximize and treat this patient? From our standpoint, if we're doing wound care, we're providing that, but then also, how did they get the wounds? Is their wheelchair not fitting appropriately? Do we need to get them a new seat cushion, a new wheelchair? That's how we're thinking to say, okay, how can we help prevent any sequelae of a patient's diagnosis? Now, I've already mentioned to this ad nauseum, it's not just us running the show. Yes, you are managing things, but then you're also working with colleagues. I have the University of Kentucky neurologist on speed dial. I call them sometimes in the middle of class. And this particular patient, here's what I'm thinking of doing, or hey, they brought up this concern. What do just want to give you a heads up. I'm talking to our neurologist. We have Epic here, and so I'm messaging the neurosurgeons and nerd crew to say, hey, what's going on here? And so it is not uncommon for me to have a couple of Epic conversations going on about patient care, potentially during clinic while someone is being seen. Because the other fact of the matter is if someone has a spinal cord injury or a stroke, it takes a lot of time to get to our appointments. And that's not even saying the patient that drives 3 hours to see us. And so if we're able to maximize their time while they're here and help coordinate care, it's going to be better for the patient. So I have alluded to all of these, at least most of them, but from a neurologic standpoint, this is just a snapshot of the things that we take care of as physiatrists. Spinal cord stroke, MS, peripheral neuropathies, some of the ones I didn't mention, Parkinson's disease, dystonias, motor neuron disease. These patients that have these conditions have rehab needs, and that's where we come up and are the experts. From a musculoskeletal standpoint, does someone have sports-related injuries, work-related injuries, repetitive issues, chronic acute back or neck pain, osteoporosis and arthritis and pain due to such? Do they need rehab after a joint replacement, amputee medicine? Really, if there is a musculoskeletal concern or report, we, with going through a PM&R residency, you are well suited to treat those conditions. All right, so for the 4s, that new PM&R that's already going into PM&R, now's the time to wake up and pay a little bit of attention. So here are the different career opportunities. So I'll be very honest with you. I knew PM&R was very broad, but once I got into it, I really didn't understand just how what you can do as a job. So if you want to do inpatient and only inpatient, you can do that. So if you want to go into practice and have 14 beds where you're taking care of a mix of rehab patients, that is totally plausible. If you want to only do outpatient, that is possible. You'll notice a day in my work week is it's mixed. I have some days that I'm seeing inpatient and outpatient folks. I have some days where I'm only seeing inpatient. If you want to do inpatient, it doesn't always have to be that you're managing a rehab unit. You could do inpatient consults. So we have an inpatient consult attending that what his job is when the liver transplant team calls and says, hey, we have a consult for you to help with the rehab needs of our liver transplant patient, that's what he goes and helps with. And not only what are the rehab needs while they're in the hospital, but can we as physiatrists help in essentially prescribing the degree of rehab that they need after their acute care? Absolutely. Do they need to go to home health? Do they need to come to acute rehab? Do they need to go to what's called subacute rehab? That's as an inpatient provider on a consult service, that's what you're doing. So, what I would recommend as the fours, as you're getting into this, get an idea of what you like and as you experience it. For me, most of my PM&R experience was all outpatient. And so I think that's why in my mind I had that I was going to go outpatient, and then I fell in love with inpatient. And so get an idea of, get some experience into inpatient and outpatient, and then decide, what do I want to do with my career? Do I want to go into fellowship or do I not want to do a fellowship? And this is all of the fellowships. I've scoured the internet to make sure that I have included everything. I even have included, shout out to Shannon Strader. She is at the University of Louisville. She is the first PM&R resident to go into a cellular therapy fellowship at Mayo. So kudos to her. With the degree of training that we get, there is really a fellowship for everything and anything, if you so choose. Hospice and palliative care, neuromuscular. The other thing is do you want to go into academic versus private? Now, academic medicine doesn't necessarily doesn't automatically mean that you're going to go work for a university. Maybe you want to go work for a medical school, or maybe you want to be in a private practice setting, but then have a whole lot of medical students that come with you. Or you might be in the camp of saying, you know what, I kind of just want to focus on what I'm doing for the day. Maybe you either don't like teaching, or that's just not something that you're passionate about, and you want to go into private practice. So these are all the things that you're going to have to think of as you're into residency to say, how do I want my practice to look? What does the job outlook look like if I do or do not pursue a fellowship? And then on top of that, do I want to practice in more an academic or a private setting? So a day in the life of. So I always appreciated these when I was a medical student to say, gosh, okay, you love what you do, but what's your day like? Are you waking up at 3 a.m. in the morning? Absolutely not. If I was waking up at 3 in the morning, probably wouldn't be doing PM&R, but probably would be. Here's my day. So this is a day that's kind of a mixed day. It's outpatient and inpatient for me. So, around 6:45, 7:15, I'm doing quote unquote table rounds, and all that I'm doing is I'm looking at the night of, looking at nursing notes, checking vitals, seeing if anyone is unstable that I need to go see them first. I would say, depending on the census, rounding takes anywhere from 1 to 2 hours. So, for the past little while, we've had about 12 patients consistently on my service. I'm an academic service, and so we have a cap of 12 patients. But today I had a lot less patients, and so rounding finished up earlier, and so we took that time and utilized it for education. From 10 to noon, after you round, it's looking at notes, following up labs, taking a look at patients. And there is so much learning opportunities. If you go in and just sit in the therapy gym and watch your patients, you will find so much. And as a medical student, I really encourage you, the patients that you are following, go watch them. And then talk to your resident that you're working with, talk to your attending and say, hey, I noticed this when so-and-so was working with therapy. Not only is that going to be amazingly educational for you, but you're going to look like a rock star if you're observing patients in therapy and be able to, provide that information to the team. From clinic, so clinic is anywhere from 1 to 2:30. I've kind of branched out my clinics a little bit longer just because the need has gotten bigger. And so my clinics are typically going from about 1 to 3:30, 4 o'clock. And then at that point, I'm wrapping up things after the day. I'm talking with the resident if we're in clinic together, kind of debriefing on some stuff. We might be seeing admissions. And then I like to do kind of a check-in or a second round. So before I leave for the day, I go in and check in on patients just to make sure that therapies went well and that we're heading into the night to doing well. I do that not only so, the patients know that I'm there for them and I'm caring for them, but also get the opportunity to talk with families, and then also helps our call team. So if there's an issue heading into the night that I can take care of, I obviously know the patient. And so, don't want to have to make our call team take care of things. And then, I wanted to kind of just address another day that is, and I have some days that I don't have clinic, and in those days we're just doing some education or catching up on paperwork or what have you. But once a week, we have what's called interdisciplinary team conference. So if you took anything from this, if you're new to PM&R, you notice that, man, we work with a whole lot of people, and we do. Once a week, we have a formal meeting with everyone. And so we're rounding, doing the table rounds, rounding with the medical team. And then our team conference is where we're meeting formally, and we provide the medical update as to what things we're doing, what are the issues that are preventing them from going home or to their next discharge destination. And then therapy is providing their updates. Nutrition is providing up their updates. Nursing is providing their updates. And then, of course, you get this little thing called insurance that weighs in and says, you know what, a patient like so-and-so is normally going to stay in rehab for this amount of time. And so then we're taking all that information to say, okay, how can we ensure a safe discharge for so-and-so? And that's where we're coming up with that information. Also, typically on my interdisciplinary team conference days, we have a thing called stroke education. So that's where we meet with our patients and we go over what is a stroke, how to prevent stroke. So they are provided with more education. We're actually redoing that, so it's on pause at the moment. But we're probably going to have a little Family Feud style coming at you here for our stroke education, just to make it fun and enjoyable. And on those days, I don't have, if I don't have clinic, we're working on notes, working on admissions, checking in folks in the afternoon and going from there. So I know that for the fours, this was a very high overview, 1,000-foot view of PM&R. And so I really hope you at least took something from the back part of that. But I am happy to answer any questions that you guys have. If I have to jump off at 8:30, I will put my email in the chat. If you didn't get it up on the screen, I'm more than happy to answer any questions you guys might have.
I have a question.
Absolutely.
You mentioned it already and you gave a summary, but I wanted to, if you could talk a little bit more about being in academic medicine, but not being at medical school or university.
Yeah, absolutely. So I would say that one of my mentors and preceptors was like that. So this individual practices in Hazard, Kentucky. He's a graduate of our program. He is associated with a hospital system called ARH, which is Appalachia Regional Hospital. And so he doesn't have residents that work with him all the time. He is pretty much a one-person show, but he has relationships with different schools, or he is a quote-unquote preceptor that if you were to say, hey, I'd like to do a rotation in PM&R, his name is going to come up at quite a few schools. And so, gosh, for a time there, I think I was sending almost anyone who wanted to do PM&R that was kind of locally. I said, man, go get some experience here because, you kind of get a unique exposure there. You get an idea of what, his life looks like as a pretty much a private practice doc. But then from his standpoint, he's also getting that experience to teach. And it's a very different level. I'll never forget, I had a patient that went orthostatic, and I was kind of looking out over things. He was kind of working on some stuff. And I'm like, oh my gosh, what do I do? What do I do? Person's orthostatic, their blood pressure is low. And he's like, well, I think you probably just need to give a bolus. So it's a different type of, right? It's just a different type of education. I, didn't have the experience. And, I think I talk to him pretty frequently. He loves what he does, but he he's getting his paychecks and stuff from a non-academic institution, but is still teaching quite a bit.
Okay. I don't want to monopolize the time. But I did want to ask, could you then juxtapose that with like being at an academic center? Like obviously being an attending, like it's your responsibility to teach like each of the levels below. But then like say like if you could talk about the potential for involvement like in the curriculum of like medical students or residents as well.
Yeah, absolutely. And tell me if I don't answer your question, I'll definitely try to reword it. So for me, one of my passion, and please Hunter or Kate, tell me if you need to kick me off, just kick me off because I want to be respectful to the next person. So for me, it is such a joy and a pleasure for me as I'm rounding with a medical student that's a 4th year AI, a 2nd year resident, and someone that's just shadowing. And we're talking about spasticity and how to use Botox. I'm gonna teach that a little bit differently, but to each person, because they're at a different level of education. But at the end of the day, I find it just such exhilarating. I guess I'm a nerd like that, so everyone understands it at the end of the day. And so, it really is a finesse, because the person that's shadowing that doesn't know if they want to do PM&R versus the 2nd year who might want to do it, I'm going to explain things differently. And so you kind of don't get that in a non-academic facility. But for me, that's what I love. I love the what did someone say? The inquiry that is involved when, we're talking about a patient and I'm saying, what do you want to do? And then going through that process as to say, hey, this is not a bad decision, but there's a better decision. And let's talk about why that is better. But you're not wrong. And here's why you're not wrong. So that's kind of more what you get in an academic facility. Today I think is a perfect example. We didn't have many patients on the unit. And so my afternoon, it was spending time with Dr. Matthews, who's one of our 2nd year. And we spent an hour and a half talking about stroke syndromes, vascular supply of the brain, and stroke rehab. If I was in a non-academic facility, I probably wouldn't have done that, but that's not what my passion is. My passion is teaching, and so that's kind of the difference with a teaching at an academic facility and then teaching but not at an academic facility. I hope that makes sense.
Yes, it does. Thank you.
Dr.
Absolutely.
Elwert, thank you so much for speaking tonight. I'm going to go ahead and introduce the next people, but I believe you said that you're happy to hang on for just a few more minutes. If anyone has more questions, so you're free to drop that in the chat. So without further ado, I'm going to introduce our next speaker tonight. Let me get this pulled up. Tonight we have